Hello, good evening, everyone. I'm Rupa Biswas, and today I welcome you again on today's session of non-invasive mode of ventilation by Catherine Aguilar. In our last session, we have discussed on various modes of ventilation and the parameters that are required to be monitored, such as the resistance, the compliance, the time constant, and also we have discussed on modes, the synchronization, the non-synchronized modes, the CMV, the patient-triggered ventilation, patient support ventilation. In today's session, we will discuss in detail about the non-invasive modes. Over to you, Catherine, ma'am.
Thank you, Rupa. It's a very nice presentation as usual. Yes, so I was asked to do some presentation on different things on the ventilator, but on ventilation, one of the important facts is that nowadays we use more and more non-invasive ventilation, as is really a trend that we should push further, because we know that invasive ventilation might be injurious to the lung, and we should favor as much as possible non-invasive ventilation. So because it's taking more and more place in the NICU, I think that it was quite important to review a little bit the different principles, what we should pay attention to, and also the different modes that you have available now on the market, and which might be used differently in different kind of patient. So is what I plan to do today. So I will share with you my presentation. So this one is on the non-invasive ventilation. So the first things that we saw for the non-invasive ventilation was actually quite early, because in the 1921 we already had the non-invasive ventilation with the Cpap, but it wasn't done on a regular basis until 1970, after it was described more precisely by Gregory's. After, we didn't use it so much actually, because we had some new treatments for the patients, like the exogenous surfactants, so which gave quite good results. So that's why it was a little bit abandoned until in 1980s. There was a study which was done on babies in Children's Hospital of Columbia University, which was showing a clear decrease, a very important decrease in BPD when they started ventilation with Cpap instead of invasive ventilation. So from then, we had a new interest again on the Cpap, and since then, Cpap has become like a primary mode in the NICU. So just a reminder of what it is. So what we do when we use NIV and Cpap is we balance the forces that we have to keep the lung open. Normally we have some surfactant inside the lung, which will keep the lung open. But whenever you have a patient who has a deficiency on surfactants, your lung or your alveoli will have the tendency of collapsing. So when the alveoli collapse, it means that it will become harder for the patient to breathe. So what will do the Cpap, it will maintain your alveoli open to maintain your FRC to your patient, and then they don't have to increase the work of breathing just to open up the alveoli, right? Because it's what is happening. It's very difficult to open up the alveoli, but once they are open, of course, it's quite easy to move them. So the comparison that you can have is, for example, if I could give you a balloon, a new balloon that birthday party, for example, those balloons at first are very, very difficult to inflate. Very difficult to inflate. Once you start inflating the balloon, it's quite easy to inflate it more. It's really the few first seconds where you have to put a lot of pressure. It's exactly the same for the alveoli. It means that if your alveoli is already open and that you want to inflate it, it's quite easy, but when it's collapsed, it's very difficult. So what are the benefits of the Cpap? The nasal Cpap is, as I mentioned, is to increase your FRC by keeping your lung open. So to avoid the lung collapse at the end of your exhalation. So you can expect a decrease in atelectasis. Of course, if you have a decrease of atelectasis, it means that you have more alveoli which are available for the gas exchanges. So you will have a better compliance, and you will have also a reduction of your VSQ mismatch, where you have some alveoli collapse. You might have some blood coming to the alveoli, and no gas exchangers at that level. But also what is important is that when you have some babies, the preterm baby, we know that they face another problem, which is apnea, the obstructive apnea. And here, the Cpap will help you to stabilize the chest wall and the upper airways by splinting the airways. So you will minimize the obstructive apnea because of that. So it will give you a decrease of the work of breathing. And we know that if you apply Cpap also, it will better preserve your surfactants when it's used very early. Of course, the Cpap can have also an impact on your cardiac performances, but on the other way around, it means that if your Cpap is not set properly, it might have a negative effect on that time on your cardiac output. So be careful with that. It's also, it will reduce the alveolar edema. You know it, that when you have a patient having a very transient tachypnea, for example, of the newborn, by increasing the Cpap, it will reduce the alveolar edema. You will help in the resorptions actually of the. So the indication will be whenever you have an increase of work of breathing. So when you have any sign of increase of work of breathing, like a moderate or a severe dyspnea, for example, with a respiratory rate, which is maybe 30% above what you can expect. So if you have any sign of nasal flaring, grunting, substernal or suprasternal extraction, cyanosis, pallor, any kind of sign like agitation as well, which might indicate that you have an increase of work of breathing, we will support the patient, maybe first with NCPAP. But also we will look, of course, at the blood gas. If you have a blood gas where the patient has some problem to maintain a PaO2, which is above 50 millimeter of mercury, with a FiO2, which is below 60%, for example, you will consider at that time certainly some Cpap or at least some non-invasive ventilations. If you have also the X-ray might help you also to decide to go for non-invasive. The indication, you know them. So it can be the apnea of the prematurity with the obstructive or the mixed one. It can be done in post-extubation where you might have an increase of work of breathing. Whenever you have a disease with some atelectasis, because you might be better able to keep the lung open. When we give some surfactant, of course, when we have some pulmonary edema, and you have quite a number of indication for that, which are well known from you, like a transient tachypnea, for example. But sometimes we might use it also in NO. So it can be also used not only for the pulmonary problem, but it can be used also when we have some congestive heart failure, for example, because the increase of pressure at the lung level will impact also the outputs of your heart. So those one are the different indications that you will have. But what we have to keep in mind is that NIV is not for all patients. And this one is very important to select the patients that you will do some NIV. We have some contraindication. So the main one, of course, will be when you have some upper airway abnormalities where you might not be able to deliver a proper NIV, or which can be injurious for the patient as well. Of course, if you have a patient with a severe cardiovascular instability and impedance arrest, you don't use NIV, you intubate immediately your patient. We might have some problem also if you have a patient who has an unstable respiratory drive with frequent apneic episode resulting in very severe desaturation and bradycardia. We might intubate the patient because I mean, if the patient doesn't have to be able to do NIV, it means that the patient needs to be able to support his own ventilation. So if the patient has too many apnea with a very severe bradycardia, it might be injurious for the patient, and you should consider intubation at that time. The contraindication also is that if you can't maintain a PaCO2 which is below 60 and your pH, maybe you will have to choose some invasive ventilation. We are quite cautious when we have some congenital diaphragmatic hernia, and to avoid gastric over distension, which might actually worsen the situation of the baby. So then you have maybe to put a catheter, a gastric catheter, to make sure that you can empty the stomach of the patient if you have any gas going to the stomach of the patient. But what we shouldn't foresee, actually, a thing that is very important for us is when to stop NIV. NIV might not be for all the baby. If we should try NIV, if the patient is okay, we should also recognize when to stop NIV. Why is it important? It's an important parameter because you have some study which support that if you go to NIV and you delay too much the intubation in the patient who have some failure in NIV, the outcome of this patient might be worse actually than if you had intubated your patient directly. So if we want to avoid intubation as much as possible, it's important for us also to recognize that some patients might not be suitable for NIV, and then don't hesitate to switch to invasive ventilation. So when are we going to switch to intubation, to invasive ventilation, is whenever we will have apparition of the contraindication. If we see that despite all the setting, the fine-tuning that we have done, we can't decrease the work of breathing of the patient, we don't manage to do it, it means that the patient will be exhausted and it won't work at the end. So we might consider intubation. If you have any worsening or no improvement of the respiratory failure with a PaCO2 which says above 55, PaO2 maybe which is below 50 millimeter of mercury, maybe a pH which drop below 725, then you should consider intubation. So NIV is must try, definitely. As much as possible, we should avoid intubation, but it's really the lesson that we have is don't delay intubation if you have a failure in non-invasive ventilation. The criteria, the criteria that you have also can change. So for this one, for example, it was a study which was done by Professor Dargaville in 2013, where they try to find the predictor actually for the failure in Cpap. And the criteria for failure might be different from the ones that I gave to you. So if you look here, the Cpap failure for them, whenever they were using a Cpap which was above 8 millibar, with a FO2 which was superior to 45 to 50% of FO2. So you see, you can have your own criteria. So in the study, what we found out is that your risk of failure was higher if after 2 hours of non-invasive ventilation, you had to use a FO2 which was above 30% in the patient of 25 to 28 weeks of gestation. But in the patient, the criteria, it was a cutting criteria for failure, risk of failure, increased risk of failure, or people or patients who are fine in non-invasive. For the patients, older patient, 25 to 28 weeks, it was the same criteria, but at 6 hours of Cpap. So it might give you an idea when to switch maybe from invasive, non-invasive to invasive ventilation. So whenever we do some NIV, monitoring is still important part of what we do. So we should, as much as possible, if it's available, transcutaneous monitoring will be nice. If you can have SpO2, of course, through the pulse oximeter, very important one. And if you are lucky enough and you have some transcutaneous CO2, is something that you should keep. But we have also some other indicator which might give us some information is our ECGs. If we see that the patient is bradycardiac, for example, or the patient is tachycardiac, it's maybe the support which is not sufficient. So as much as possible, we will try to monitor also the respiratory rate of the patient, which might be a good clue of the work of breathing of the patient. Times 2 times, we should do some ABG to help us to know where the patient is, because SpO2 might not be sufficient to know exactly where we are. Of course, we will monitor the patients, and here is very important in NIV to assess the work of breathing just by looking at the patients. If we see that we still have some grunting, if we see some retraction, we know that the work of breathing of the patient is high. So here is also help you, it will help you to set your parameter. If you see that your patient, for example, is still grunting, maybe we will go a little bit more on the Cpap and see what is going on. We might see, for example, if we increase the Cpap, but we see that the chest movement is becoming smaller, it might tip you that you increase the Cpap, but you see the chest movement, for example, is smaller, might tip you, for example, that you went a little bit too high, that now the FRC is too high and your lung can't expand so much as well. So it will help you always look at your patient. Whenever we have non-invasive ventilation, we have far less monitoring to guide us on the tidal volume, such kind of things. So here it will be important to have a physical assessment of the patient. So you might consider also some chest X-ray. If you have any incident, if you have any changes, chest X-ray might help you. At the same time, because we will use some different interfaces to deliver the Cpap, we have to make sure that we don't injure the patient, we don't generate any injury, and we have to look on a regular basis, actually, if we don't have any injury at the level of the interface. We have to consider that we can have some complication in NIV. Okay, so we can still generate some over distensions. If we generate some, if your FRC is, if you go too high on the PEEP, what will happen? It will be like if I was asking you to take a breath, you stop at the end of the inspiration, and then I tell you now on the top of that one, you try to take a new inspiration. It will be very difficult for you. So this one is over distension that we can generate actually with non-invasive ventilation. If we set a pressure, low pressure, which is too high, FRC is too high, and you might generate some over distension at that time. So here you have a risk of intrinsic PEEP, but you might increase pressure in the lung will increase. So you might increase the pulmonary vascular resistances. And be careful, for example, if you have a primary PPHN, because those patients, they already have some resistances which are very high. And if you don't use a appropriate PEP in those one having a primary PPHN, a level of PEEP of, for example, 7, 8 might already generate a little bit of over distension. So be careful with that. If you generate some over distension, you will have some ventilation perfusion mismatch, CO2 retentions, and of course you have a risk of air leak syndrome. It will increase, you might have an increase of work of breathing at that time as well. If your PEEP is too low, also you will have an increase of work of breathing. We might have some gastric insufflation and abdominal distension, because you will see that when we push a breath, that is the gas sometimes doesn't go to the lung. And of course, it's all the injuries which are linked to the interfaces themselves. Okay. So be careful also to have a proper humidification of your gas, because you have to keep in mind that our medical gases are very dry, and that the patient, we should humidify our gas. Okay, so what's which interface you should use. There are a few studies which support actually the use of short binasal prongs, where it seems that you are better able to transmit the pressure. You have less pressure loss in the interfaces, and you can have also a good sealing whenever you deliver the CPAP. So whenever you use a CPAP, you will have two types actually of CPAP. The first one that you might have in your ventilator is what we call a continuous CPAP. So what is this one? So this one is a type of CPAP that you have here. You will have two limbs on your CPAP. So what you will set here, you will set a CPAP, for example, of 5. If you set a CPAP of 5, the ventilator will be pushing something like 8 liters per minute. Okay, so to generate a CPAP of 5. So during the inspiration, the patient will receive 8 liters per minute, whatever the breath he's taking. Small breath, deep breath, doesn't matter. He will receive continuously 8 liters to generate the 5 millibar of pressure. When the patient will be exhaling, he will be exhaling against 8 liters per minute. So if I look at the flow, what you see here is that the flow is very constant. It doesn't change. But if I look during my inspiration, for example, you will see that the CPAP is decreasing a little bit, normal, because the patient is generating a deep pressure. And when the patient is exhaling, because he's exhaling against the flow, then you will see that the pressure will be increasing, is what you will see. So you will see some fluctuation here on the CPAP. What are saying the trials? You had different trials. The first one is a COINS trial, which was showing no difference in outcomes in either mortality, BPD, O2 dependency at 36 weeks or 52 weeks. But then you had another one, INSURE one, where they had a 40 infant randomized to intubations or surfactant plus extubation, and then to NCPAP or bilabel. And then what they saw is the improvement in the length of respiratory support. When they look inside the lung, they found less cytokines and also less O2 dependency. It means that lower rate of BPD in those patients. And then a new study in 2004, where we're showing early extubation plus surfactant and then CPAP was beneficial outcome and was recommended. So I think that now everywhere in Europe, in Asia, your recommendation will be to use a CPAP as much as possible. Now you have another type of CPAP. The second type of CPAP that you have is what we call variable flow CPAP. If you look in the interface that you will use, you will see that then you will have a different kind here of your expiratory port. Here is the expiration limbs, you see is free. You don't have any circuit coming here. And this one is variable. It means that if I take my interface here, which is a generator, what I will do, I will push a flow to make sure that I have the CPAP that I want. For example, still my 5 millibar, I might be around 8 liters per minute here. But what will happen, you will have 50% of the flow going to the patient and 50% going to the expiratory limb. Yeah, because the pressure here is exactly the same as this one. That's why my flow is equivalent. But now, whenever a patient takes a breath, what he will do, he will generate, by starting a spontaneous breath, he will generate a negative pressure. So now the pressure is less important here than here. So automatically you will have more gas diverted to your patients. And is what is happening here. It means that here, the patient, now you might have 60% of the gas going to your patient and only 40% going to the exhalation. And what is very nice is that if your patient wants to take a deep breath, he will generate a bigger depression. So the depression will be more important here. So you will have more gas diverted to the patient and less gas going to the exhalation. So that's why we say that is a variable flow Cpap or Cpap using the fluidic principle is because at that time, when your patient takes a deeper breath, he has more flow coming to him. So the work of breathing will be decreased. The second point that is very nice is whenever your patient is exhaling, of course, he will be exhaling against the flow. So you will see the pressure going up at the level of the interface. So at that time, because the pressure is higher here, you will have more flow going to the exhalation at this time. So the patient will be exhaling against a lower flow, against less work of breathing. So whenever you use a variable flow, you will see that your work of breathing will be decreased. So you have different studies here showing you that whenever you use a variable flow compared to the constant flow, you will have a greater lung volume recruitment. Whenever you use a variable flow, you will have a decrease of work of breathing and more, you will have less asynchrony that compared to the bubble Cpap, for example. And quite important, you will have an increased VT and the thoraco-abdominal synchrony, which is better when you use a variable flow. So it means, again, that you will be decreasing the work of, when you have a decrease on the variable flow. Okay. So, but we couldn't find any difference in your need of intubations, need of intubation or reintubation. It was quite similar at the end. Now, what you will see more and more in the ventilator is we use NIPPV. So NIPPV is exactly like CV, CMV that you had in ventilation, but in non-invasive ventilation. It means that here what we'll do, we will be at the Cpap level, and time to time, we will deliver some breath to the patient. So again, you will have to set how many breaths you want to deliver to the patients. You will have also to set how much of PIP you want to deliver to the patient and the inspiratory time. So what do we expect? Do we expect from the CMV when we use NIPPV? We don't, the problem that we face is that we don't have any synchrony. So we might not expect some synchrony with the patients, but we will be working at 2 levels of patients. And then it will be like giving a sigh to the patients. And we hope by going a little bit higher on the pressure that we might be able to open up some alveoli which were collapsed, and we might do a little bit of lung recruitment. Whenever you have apneic patients, you might increase the patency of the upper airways, but also the intermittent inflation might be a kind of stimulation that you give to the patient, and you might increase the respiratory drive of your patient. So whenever we have a patient doing, for example, apnea, we might touch the patient to stimulate the patient. But in some ventilator, what you will have some increase of pressure when the patient goes apneic. Why? Because the increase of pressure might give the reflex of the patient to take a breath. So we think that when we have an IPPV, we give on a regular basis those increase of pressure, and we might stimulate the patient to breathe also. And we might give him the head paradoxical, for example, reflex at that time to breathe. And it will also increase a little bit your map. So it's what we expect from the NIPPV. So when we look at the study, what we see is that the early extubation immediately after the post-surfactant to synchronize, we had a duration of extubation and decrease of need for oxygenation. We had a reduction of apnea when we compare NIPPV compared to Cpap. But in some cases, actually, we didn't find any differences. When we look at the Cochrane review, which look actually at the NIPPV compared to the Cpap, but we have to be careful because when we compare NIPPV, actually, they didn't differentiate the synchronized NIPPV to the non-synchronized NIPPV. But what we found out is that when you use 2 levels of Cpap, it seems that you had a decreased risk of extubation failure and reintubation within the 48 hours to 1 week compared to Cpap. But they didn't find any difference against on the BPD and the chronic lung disease, the mortality. What we found out is that when the NIPPV was delivered through a ventilator, it seems that they had a better outcome than the bilevel system like the Cpap, for example. But we have to be careful. Why? Because when we look at the study, what we find is what we look at the effect of the non-synchronized nasal intermittent positive pressure ventilation on the spontaneous breath is that it might not inflate your lung. You might not see an increase of the chest whenever you when you deliver a breath. Why? Is because if you push a breath, but your patient is not breathing at the same time, what you might see is this one here. The patient actually might have his epiglottis closed. If the patient's epiglottis is closed, you can push a breath. It will go just to your esophagus. And is what is seen here. You see here, for example, you have some NIPPV. The ventilator is pushing some breath very nicely. But when we look at the lung, you see here, you don't have any gas going to the lung, and you see the SpO2 of the patient going down here. Why? Because the epiglottis of the patient is closed. So don't expect maybe too much for NIPPV. In about 30% of the cases, you might have some synchrony with the patient. If you have a synchrony with the patient was taking your breath at the same time, what you will see is your tidal volume going up at that time. But if not, you might not see it. So again, you might face the same problem than in CMV. It means you might generate some asynchrony. You can imagine that, for example, your patient took a spontaneous breath and the patient wants to exhale, but at the same time is a time for an NIPPV breath. The ventilator is pushing your breath, and then the patient will have to exhale against the ventilator, and then you might increase the walk of breathing. So NIPPV is better than Cpap to decrease the risk of failure in post-extubation. It might stimulate more your patient to take some breath, actually, for the respiratory drive, but you have to know that you might generate also some asynchrony. So what do we use usually? What is the setting that we mostly see is a PEEP, which is between 5 to 8 most of the time, and a PIP, which will be titrated between, quite commonly, 14 to 20. But of course, it might be less if your patients, you see that you have a nice response of your patient. The rate, commonly we'll see something between 10 to 40, and the expiratory time is quite often between 0.3 to 0.5, or sometimes a little bit higher as well. So as usual, we titrate regarding the Cpap. For example, if you see that you set a Cpap of 4, but you see some grunting, some retraction, you will go a little bit higher. And then the PIP, you will see regarding the inflation of the patient. Okay. Then you have the Cpap. So that one, it will be 2 levels of pressure, but this time the 2 levels of pressure will be like your variable flow, and it means that you will have 1 level of Cpap and then the second level of Cpap. Here the setting will be a little bit different. What we expect from it is very similar to what you expect from the NIPPV. It means that you hope that you will open up some atelectasis by going a little bit higher on the pressure, and that you will decrease the ventilation perfusion mismatch as well. And here, the settings that you might set, usually what we see is the PIP, which is set might be only 2 to 3 millibar above the PIP that you set. It's quite common setting. In some ventilator, what you have now is NIPPV trigger. So this one, it means that the ventilator will synchronize with your patient. So some of them might use some the grasp-by, for example, capsule, where it will look at it will be put on the abdomen. When your abdomen, the patient takes a breath, it will expand the grasp-by capsule, where you will have a decrease inside. It will sense it, and then it can pick up the breath. Zinc synchrony is not perfect. It's far from being perfect. You have a number of mistrigger where the patient won't pick up the breath of the patient, or the other way around, might see some breath where you don't have any breath. If you work with the SLE ventilator, what we will be using, it will be a pressure trigger. And the pressure trigger, we will pick up when the patient takes a breath and generate some depressions. So it can be done because the pressure trigger will be quite proximal here, and we can read it. So what is the advantage here is that the patient will take a breath. When the patient takes a breath, the ventilator will synchronize with the patient. And here you are sure that the glottis is open. So whenever the patient takes a breath, then the ventilator will push a breath to your patient, and you will see really the tidal volume going to the patient at that time. It's like a PTV in what I explained to you before last time. It means that here, if the patient takes a breath, the ventilator will synchronize with the patient and push a breath. So he will have a tidal volume which is bigger. So the patient might also slow down his respiratory rate, for example. The patient at the same time, if the patient goes apneic, what will happen? The ventilator will push some breath. And this time, when he pushes some breath, what you might have is some stimulation to your patient to breathe again. Patient start breathing again, and then what you will see is that your patient, the ventilator, the glottis is open, so the tidal volume will go to the patients. So here you had some studies where they look at the synchronization of the patients. When you deliver some NIPPV, synchronized one, in stable preterm, and what they saw is that the spontaneous inspiratory effort of the patient was really reduced when you compare it to non-synchronized IPPV and even from Cpap. Some other studies were showing that actually NIPPV synchronized one was more effective than NIPV and Cpap to treat the apnea of the patient in the apnea of the prematurity. So they had, because of that, they had a lower rate of desaturation and event of bradycardia during the synchronized one. And it was quite important because they had in synchronized, they move from 6.3 apnea and desaturation per hours when you were in NCPAP to 5.3 when you were in NIPPV, and to 2.4 when you switch to synchronize intermittent one. So they had a quite important decrease of event of desaturation, and because less desaturation, less bradycardia also. So 40% decrease. When we look at that one also, what they look another study where they look at synchronized intermittent positive pressure compared to invasive ventilation, and then they saw that they had a quite important reduction of BPD compared to conventional ventilation, but in invasive. Another parameter that, so which setting you will set is quite similar to the IPPV one that you will get. So the other thing that you will get is what we see more and more is NHFO. So you might be surprised actually to have some nasal HFO. I don't know if you use it, but it's more and more widely used. Why is it interesting? You remember that when you do some HFO, we didn't talk about it, but HFO is called sometimes like a super Cpap. So when you deliver some HFO, you will deliver a MAP, minimum waist pressure, which is considered as a Cpap. So that one, the MAP will be the one maintaining your lung open, and it will be the one maintaining your FRC. On the top of that, when you have some HFO, you will push some tidal volume and suck out your tidal volume is what we are doing. So here, what is very nice is when you do some HFO, it will be somehow like combining two modes. You will be delivering a Cpap through the map that you set in HFO. So it will keep your lung open. And at the same time, it will be like doing some high flow nasal cannula, where you do some high flow nasal cannula. One of the important parameters is a washout of your upper airways. So when you have a high flow nasal cannula, what do? You push some fresh gas here, which will chase away the CO2, the gas which was coming from the last expiration here and which was staying in your upper airway. So you will chase this gas by some fresh gas. So whenever your patient starts a new breath, you start with some fresh gas and you don't have any CO2 rebreathing that was due to the gas that you had staying in your upper airways. So here what we will be doing, the ventilator will push some tiny breaths and we suck out the breath at the same time, so you will wash out your CO2. So you maintain a MAP, you maintain a Cpap, and at the same time, you wash out the upper airways. So when we look at the studies regarding that one, what was shown is that the NHFO actually was, when we look at all the studies which were done, you see that in most of them, the PCO2 was lower than compared when we use NCPAP. It was better at washing out the CO2. When we look also the change of CO2, it was the same. So the high frequency ventilation seems to be better at washing out the CO2. Now, when we look at this study here, when they look at the reintubation rate, when they compare to NHFO to Cpap, for example, what they found out is that they had also less reintubation. It might be due because we are more able to maintain a proper CO2 in those patients. So what the study are saying? What the study are saying is that NHFO seems to be superior to avoid Cpap in reintubation, especially in very preterm baby below 32 weeks. So this one was done on 206 patients, so quite important number of people, of patients, and is what we found out. You had another one where we look at the desaturation and bradycardia in very preterm infant, and what they reported, it was less episode of desaturation infant and bradycardia decrease in the patients. Most of the patients, in one of the patients, actually, they had a little bit more, they had more episode. So for those patients born between 24 and 30 weeks, when they compare it to Cpap. So one of the idea is that actually the small oscillations that they have might better keep the patency open of the patient. And at the same time, you might have a different kind of stimulation of the patient, which allows you, the patient to have less apnea. An important factor that is that whenever you push a breath, you might have the glottal constrictor muscle closing. Is whenever the patient will feel some air going to his lung, he might protect his airway by closing his glottal constrictor muscle. And sometimes, even if you push a breath, it will be closed, so you won't have any gas going to the patient. And there's a risk whenever we do some IPPV or even synchronized IPPV, we might have the reflex of closing. So what we have found in the lamp is that you don't have, when you do NHFO, you don't have any kind of, you don't have this kind of reflex. But what we found out is that when they were going quite low on the rate, they had a tendency of the patient of stopping breathing. So the thing is, certainly don't use too low frequency also when we work in HF. So What we see here, we had a European survey, and we should look at what they were, the settings that we had. And in post-extubation phase, they were setting a map which was around 8 most of the time, and they had a delta pressure most of the time, which was at 25%. So don't expect to see some vibration of the chest. Sometimes you might not see any vibration of the chest. It's fine with that. No worries about it. What the studies have shown is that when we look at the electrical impedance, we see that part of the tidal volume will go to the lung, and the repartition of the tidal volume at that time when we do an HFO is also more even in the lung. So here you will set against your map like a Cpap. It means that if you have a problem of oxygenation, is the map of the FO2 that you will change. The delta pressure won't affect anything. And then if you have some problem of oxygenation or of CO2, which is too high, for example, you will increase the delta pressure. So which kind of interface you should use? The prong seems to be better than the mask. Why? Because the mask, you might have too much dampening and too much dead space here. So the different studies are showing that the prong seems to be better to do it. Here we have still some problem to tell you how much you should use it. Because when we look at the different studies, when we go back to the different studies, the positive one or the negative, what you will see is that you have a very wide range of setting. So for example, if I look here, you will see that in post-extubation, they were quite often around 8 to 10, but you see in patients in BPD at risk of BPD, they were sometimes 10 to 16. So very high setting. And one of the questions now that some doctor might have is if we had been daring enough to use a Cpap of 10 or 15 in 16 in some patients, would have got the same result than in NHFO. Because here when you are in the NHFO, you set the map which is equivalent to a Cpap of 10 or 16, but you won't do it when you have a Cpap. So the question was, maybe we see a benefit because when we use a Cpap, maybe the Cpap that we use, the level of the Cpap that you use might need to be a little bit higher in some cases. So this one is always titrate and see what is happening in your patient. Look at your SpO2, what is going up. Look at your chest rise. Do you go up on the map and you see that your chest rise is doing something like that instead of doing something nice like that? And you see what is happening. The delta pressure, again, we had some big fluctuation between the different centers, between 25 to 35 and 30 to 50. Yeah. Frequency, 10 to 12. There are some studies showing that maybe 8 can be a good value actually to have a frequency of 8 seems to be quite good value for the patients. So what we have noticed also when we do high frequency ventilation is that some patients might be totally uncomfortable with that. So some patients might become agitated when you have it. They are not comfortable. You might see the SpO2 going down at that time. So stop NHFO if the patients are uncomfortable. It might not work for everybody. What I will do is that if I have a patient and I see that the CO2, my oxygenation might not be so much a problem, but I have rather a problem of CO2, I will certainly consider actually to go to NHFO. But still the same idea, don't delay intubation if the patient needs some intubations. So the third mode, the last mode that you have available, and I think that you widely use it now, is high flow nasal cannula. So the high flow nasal cannula is quite widely used now. I think that even in adults, we have seen a surge of use of high flow nasal cannula with the COVID. Here, I think that with the bronchiolitis, we have a very important pandemic here, not an epidemic of bronchiolitis currently in Europe. I think that we will use a lot the high flow nasal cannula in those patients. So here, still very important, your interface. Whenever you use a high flow nasal cannula, your interface is one of the major parameters actually of the high flow nasal cannula. Just remember that the principle of high flow nasal cannula is to wash out the upper airways. Is when you take a breath, you inspire, you exhale. The last part of your exhale tidal volume will stay in your upper airways. So this one comes from the deeper part of your lung where the CO2 is the highest. Okay. When the patient takes a new breath, what he will do, it will push back, of course, the air which was in his upper airways, the first things. So whenever if you do some gas, you push some gas, you generate 50% of leak at least, and you generate a leak of 50%, of course, you will wash out the gas which was staying from the last exhalation. So that's why high flow nasal cannula is quite efficient at washing out CO2. So what it will do? The flow will generate some pressure. So we will have some pressure which is generating. The problem that we face is that we have no idea of how much of flow we generate. And when we look at the review of the protocol on the review, what has been seen is that the pressure that we generate for the same flow will widely vary, change from one patient to another one. The first parameter which will influence a lot the pressure that is generated is the weight of your patient. Smaller patient for the same flow will generate a bigger Cpap. So that's why also you put the flow regarding the weight of the patient. So then how much of flow you will be able to deliver to the patient will depend on the cannula that you use, because your cannula, each of them will have an upper limit of flow that you can give. You choose a cannula always at least 50% of leak on your cannula. If not, you might generate some pressure which are very high and you don't know it because you don't monitor it. So what do we expect from the high flow nasal cannula? So the washout of the upper airways, so less CO2 rebreathing. Second thing, of course, you will have some Cpap level which is generated. We don't know how much, but it will certainly help the patient as well. Second thing, you condition your gas, so your patient will spend less energy to condition your gas, and you will have less inflammation than if you don't have a proper conditioning of your gas as well. And of course, you will decrease the work of breathing by generating some Cpap. So here, what are the studies? When we look at the studies, it was showing that when we look at the Cochrane review, that you have quite a number of evidences to show that it is quite efficient in post-extubation support. It wasn't so positive actually when they were looking in RDS patients. When they look at they had a study which was done on the patient more than 8,000 patients, and they found out that actually it was less efficient than Cpap. But nowadays we see more and more places where high flow nasal cannula might become the primary mode of non-invasive ventilation. But you have to keep in mind that if you have a patient who is a little bit with borderline, usually non-invasive ventilation like synchronized IPPV, for example, or even non-synchronized IPPV, or even Cpap will do better than high flow nasal cannula. So when they look, for example, in studies where we were looking in the patient, they had a higher with a very low weight patient who were around 1,000 grams, we found out that we had more failure in a high flow nasal cannula. But we see that with people, some doctors who are more and more at ease with the high flow nasal cannula, that they might use to more severe patients. Again, you have to know when to switch to another one. Okay. So those one are a little bit the new mode which are available at your disposal now when you do some non-invasive ventilations. So as usual, we have to pay attention to our setting, because even if we are in non-invasive ventilation, it doesn't mean that we are not injurious. And a thing that was quite interesting, for example, is that when we look back at the different decrease of the BPD, for example, we saw a nice decrease of BPD when we started to use corticoid, when we use surfactant, we saw the Cpap. But nowadays, even if we see that non-invasive ventilation is more and more used in the practice, we don't see so much the decrease of the BPD. A reason might be because we still expose quite a lot the patient to some oxygen. Oxygen, we know that is a part, actually, is one of the factors of the BPD. If, for example, you switch your patient in non-invasive ventilation, your patient is doing quite well. We don't win the patient so fast, actually. He might stay on the non-invasive ventilation longer with a FO2, which is not at 21%. And then you will extend the exposure of your patient. You might have extubate your patient actually faster if you had a
Hi, Catherine. Hello, Catherine. Sorry to interrupt. Your presentation is not seen. If you can just please reshare it.
No, it was finished. It's just verbal.
Oh, it is finished, right? Thank you.
Okay. I mean, so the PowerPoint for you.
Yeah, thank you.
So just to add you some different informations is that, for example, your FO2 to control the SpO2, to make sure that you decrease as much as possible your FO2, to keep your patients always in the low target. Don't expose too much your patient to your FO2 if your patient's SpO2 is fine, for example. Such kind of things we have really to pay attention. Be careful also with the Cpap level. If your Cpap level, for example, is too low, you will have an increase of work of breathing. Your patient can injure his lung. If you support too much, you might generate some over distension. So you still have some fine tuning to do. Okay, so if you have any question regarding the presentation, just let me know. I hope that it was useful for you. And just let me know if you have any questions that you want me to answer.
Thank you, Catherine. It was very wonderful. We have received a few interesting questions. Let me read them out to you. The first question I think we have received from Dr. Jyoti, and she has asked us, what is the maximum PIP and PEEP that can be tried on NIV mode before switching to invasive ventilation? Any vaccine.
I would say the tolerance depends on the training. So mostly what we see quite often we see that the doctor will be quite uncomfortable to use a PEP, which is going higher than 8.
Yes,
it's quite common. But we see now we have some units where they do a lot of NIV, which will push a little bit further up, actually, and we might try 9, 10 of PEP. It might be also because you have the study showing that they had, we don't know why in NHFO, actually, the people were daring to go higher and they had a good result. So some people, they go, of course, a little bit higher, but they are very cautious. Observe your patients. If you see that you go a little bit higher, you really the shapes, if your chest rise, for example, was doing something where you had some things nice like that, and suddenly you have something where it's moving just like that, it means you went too far, expanded too much, your FRC is too high. Okay, so here is tipping you and you will see your saturation going down. So it's always titrate, see what is going on. The PIP again, you will, so is what I showed to you, 14, 16 of PIP, maybe a little bit higher. But if you see something going like that, it's not good. I mean, so you should see something quite gentle, not something where you go too far as well.
Yes.
So,
Okay, so this was one. Another question we received was, when using non-invasive mode, what interface do you advise? And are there any advantage of using trigger modes in NIV? Was asked by Dr. Kedar, and similar to this question was another question which we have received is NIV synchronized in SLE? Dr. Jain asks us this question.
Okay. So the first question, sorry, was
whether the NIV is synchronized in SLE.
So the synchronized is, you have an advantage. The advantage is that you will increase the tidal volume of the patient. So the patient will make more effort to get the same tidal volume. And each time that you push the ventilator synchronizes with the patient. So his work of breathing should decrease. You should have a nicer tidal volume at that time. Less gas going to the stomach as well. So here, because if your patient is not synchronized with your baby, the ventilator can keep pushing some breath. If you have only 3 breaths out of 10 which are synchronized with the patient, it means going to the lung, it means that you have 7 going to the stomach. So it is also better. It has shown that you have less apnea, that the effort, the work of breathing of the patient is lower. So it's quite interesting. And frankly speaking, the feedback from the doctor who managed to get some synchronized mode, they feel they are quite happy with that. So is it available on the ventilator? Yes and no?
Yes, of course.
Shouldn't say that.
Yes,
and on your ventilator. So it means that on the ventilator, if you have the SLE 6000, you have a mode which is fully dedicated. It's called NIPPV trigger. So this one, as a ventilator, you know, we have a proximal pressure lines, which make us able to pick up the breath, the decrease of the pressure when the patient takes a breath. Here, no problem, you have it. Now you might have the 4000 or the 5000. So officially, no, you don't have any trigger, and you don't have any NIV modes, actually.
Yes,
but
it's separate.
But
yeah, but
of course, means we don't have any CE mark saying that we have the NIV mark. It wasn't tested. It's not CE mark. But what we see a lot is a lot of places, if they have a baby who is not doing well, what they do, they just put the NIV interface to the patients, and then they use, for example, your PTV. If they remove the flow sensor, okay, and then they use the pressure trigger to synchronize with the patient. So officially, I can't tell you yes, because definitely a ventilator it wasn't tested for NIV.
But practically on ground.
But practically, we see a lot of places where it won't adjust as well. For example, a leak. If you have a very big leak, for example, the SLE 6000 will compensate, whereas the 5000 will be far more limited in the compensation. But if you manage to compensate, to minimize your leaks, and is where the interface becomes very important. What I didn't mention in non-invasive ventilation is that the success of your non-invasive ventilation is not only your setting, but it's all the part linked to your interface.
Yes.
It means that if you have a team where is very used to that, is very comfortable, you will see that your success rate will increase with the experience of the team. It means that the choice of your interface. So prongs, very nice. If you have two choices of prongs because you hesitate between 2 sizes, go for the highest one. you will have less leak at that time. And what happens whenever you will have a leak, you will have your nurses pushing up, usually here, to try to minimize the leaks, to try to deliver the Cpap. And this is where we have the risk of injury. Now, it will depend sometimes also on the anatomy of the patient. Some patients doesn't fit, or they have one nostril, for example, which is bigger than the other one. So here, for example, the mask will be better for the patients. So then use maybe the mask. Now, if you start to have some points of compressions where you have a risk of injury, you can alternate. Because if you use for 2 hours, for example, or 4 hours the prongs, and then you go to the mask, you will change the point of compressions. Okay. But what is very important is the choice of your bonnet, the fixation to be properly done, to make sure that you don't have any pressure on your upper lips, on your septum. Very important. So all those small things actually make it success or not. Of course, we should minimize as much as possible the leaks. Be careful, for example, when you have the tube, the circuit, that it doesn't pull up, for example, your interface, because you will end up something like that, more leaks. So put some things to keep it on high enough that it doesn't pull out your interface. It's very small things like that, but it's important actually to keep it in mind. Another factor that I didn't mention to you, are things that you have seen a lot, is that NIV on prone position.
Okay.
So if you have oxygenation problem, not only Cpap, not only FO2 increase, put your patient in prone position.
Okay.
Okay.
Prone position helps.
Yes. Yeah, it helps a lot. We have seen, for example, with COVID, we learned the non-invasive ventilations actually, and we have seen a number of patients actually ventilated in NIV in prone position. So the patient, we ask them to stay on the belly, because we know that just because of the weight of the lung, your heart, etc., that you will have better ventilation of your lung if you put your patient on a prone position. So it's few things like that can help you as well.
Yes, ma'am, and last question is from Dr. Vipin Vesh. He has requested us to just explain about volume guarantee once more. I mean, he has requested us.
May I do something where I contact you directly?
Yes, sure.
Like that, I can spend more time with you.
That he will get in touch.
You send me an email.
Yes, I will share his details.
And like that, we can spend as much as time.
Sure. Thank you. Thank you so much. It will be great. Okay, so thank you very much, ma'am.
You're welcome.
Very, very informative, and we learned a lot. I'm sure our audience also, were benefited by our discussion today. They understood about patient monitoring parameters to be taken care while they do NIV. And the interface connection, we showed them photographs of how the connections can be. We showed them the mini flow, the mini flow kit and the connections, and also the guidance on the compliance and the complications which can happen, and what are the things to especially keep in mind while doing NIV. So thank you very much, Catherine ma'am, and thank you audience for your wonderful participation. We will definitely share the recorded session with you on our website, and we would love to hear from you about your feedback on today's session as well. If you have any questions, do let us know. We will definitely try to get back to you with the answers, and we will be looking forward to your feedback. Thank you very much.
Thank you very much. Goodbye.